Perfect. So, Krok 1 Pathomorphology MCQ Workshop, Part 2 is dedicated to 2018 year. And today, the main theme of our discussion I have chosen as the Stranger Things series, because, you know, sometimes I have the association that students are trying to go upside down. So, and just to avoid that situation in Krok 1, we need to fight with our scenes, and, you know, the most pronounced scene in the preparation to the exam, that, as you may know, the laziness. So, as 11 said, in fact, no, it's just a joke, so that don't feed your laziness, get up and prepare for Krok 1. So, the first question, what I want to discuss today, that's about the autopsy of a woman revealed the following morphologic changes: stenosis of the atrioventricular opening, mitral valve insufficiency. Histologically, there are focal cardiosclerosis and blooming Aschoff nodules in the myocardium. What is the most likely diagnosis? You see, just to remind you, what does it mean, the blooming, or in fact flourishing Aschoff, not nodules but body, flourishing Aschoff body, or granuloma, which is mostly associated with okay, I just want to check your chat. So what is the option, what you have chosen here once again? Okay, E, rheumatism. Perfect. Rheumatism is pretty correct answer. It's quite well. So what I should say that in fact the name of this disease is rheumatic fever, but in Ukrainian reality, in the Ukrainian reality of the Ukrainian Krok 1, you should remember that we have our own terminology sometimes. So, and I will discuss about that today a lot, because I got some questions that I want to complain about that, but doesn't matter. We may complain a lot about the terminology, but in fact the truth is that you will be faced exactly with such kind of the MCQs, and you must be adapted to these kind of questions. So in such a way, just cross your fingers and remember that some terms you will never meet in the real life in your countries, in the Western countries, in the real English, medical English, but in Ukraine we have our own reality. So the such kind of reality you see in this MCQ, that's the rheumatism instead of rheumatic fever, and blooming Aschoff nodules. Again, that's a key word in this MCQ that you have to pay attention on and find connection with the Aschoff, name of Aschoff, who invented this type of granuloma. So the real name, as I told you before, that's the in fact the Aschoff body, flourishing Aschoff body. Good. Next question. During autopsy of 34-year-old man who died of chronic kidney failure due to renal amyloidosis in the lungs, mainly in the lower lobes, the pathologist detected multiple bronchial dilations filled with purulent masses accumulated in the bronchial lumen. Surface of the lungs section has fine meshed pattern and resembles a honeycomb. Once again. Histologically, there is the chronic inflammation detected in the bronchial wall. Muscle fibers are replaced with connective tissue. These changes in the lungs can be defined as, please, your answers, bronchiectasis. I guess it was easy for you. You have chosen C. Just to remind you how these findings look like grossly, that's indeed the bronchiectasis. You see this enlarged bronchi, and altogether they make something like build up the honeycomb pattern. So as about the honeycomb, that's the equivalent of interstitial fibrosis, and in fact, this pattern we may see on the X-ray. So that's in fact the X-ray appearance of the interstitial fibrosis. I should say that honeycombing is not exactly must be connected with the bronchiectasis, but in this case, that's exactly the point that honeycombing, that's the sign of bronchiectasis. Honeycombing may be present in different diseases, and one of them is the bronchiectasis. Okay, so bronchiectasis is the correct answer. Patient who had received a thermal burn developed painful boils filled with turbid liquid on the skin. Turbid or opaque, as you wish, the meaning of this. Which morphological type of inflammation has developed in the patient? Okay, please. C, cirrhosis. So if I will be speaking with you in Spanish, okay, I will answer the same for you. C, I will confirm that. C, yes. C, that's the correct answer. That's the cirrhosis. Nothing is complicated, nothing is difficult with this MCQ. It's quite simple. Thermal burn basically creates some kind of inflammation that we call cirrhosis inflammation. You see that there is no pus formation. That's not the suppurative inflammation. There is no fibrinous films, fibrin films formation. That's not the Krupos inflammation or diphtheric as the variant. That's not the granulomatous or proliferative inflammation, because basically it's associated with the chronic course of the process. In this case, we have very acute inflammatory response, and it consists of the exudate, which is semi-transparent or turbid liquid. So that's the cirrhosis inflammation. Next question. 65-year-old woman who had been suffering from deep vein thrombophlebitis on the lower leg suddenly died when awaiting her appointment with the doctor. Autopsy revealed loose, friable red masses with corrugated dull surface in the main pulmonary artery and its bifurcation. What pathologic process was discovered by the pathologist in the pulmonary artery? So you already answered. I see you answered. So who else? Other variants? B. Okay, thrombosis, thromboembolism, tissue embolism, foreign body embolism, fat embolism. So in fact, you see that's not the thrombosis, because the autopsy revealed loose friable red masses with corrugated dull surface in the main pulmonary artery and its bifurcation. There is no mentioning about its connection to the intima, to the endothelium. So that's embolism. Why this embolism you consider it as the thromboembolism? Just look at the key words. Yes, thromboembolism is the correct answer. First of all, the first keyword appears in the first sentence. There's the deep vein thrombophlebitis. That's exactly the source of the thromboembolus. So the detachment of this thrombi is leading to the roaming of this thromboemboli via the large veins, and following the large vein blood flow, this thromboemboli finally may appear only in one place, in the right heart. So right ventricle, right atrium, right ventricle, and then in the pulmonary trunk. You see the presence of sudden death in this case, and that's exactly the result of the thromboembolism of the bifurcation of pulmonary trunk. Exactly over there, you can find the loose, friable red masses. It looks like the thrombi, but this is not connected. This is not adjacent to the binded to the endothelium. That's why we can conclude that this is the thrombi. Once again, additional signs of the thrombi over here, which can distinguish these features from the, for example, post-mortal blood clots. That's the corrugated dull surface of that thrombi. Otherwise, in case of the post-mortal blood clots, we will have something different. We will have the quite soft and elastic masses with the bright surface, and sometimes they are resembling so-called chicken fat. So in our case, that's completely different. Corrugated dull surface, friable red masses, and that's exactly the thromboembolism. Just to remind you how they look like. That's exactly what happened in this case. You see the lungs, you see the bifurcation of the pulmonary trunk, you see the left and right pulmonary arteries, and over there, there is the saddle, so-called saddle thromboembolus, because it looks like it's sitting in the saddle horse, on the horse. Okay, next question. Examination of the coronary arteries revealed atherosclerotic plaques with calcinosis that narrow the arterial opening by 1/3. In the muscle, there are numerous whitish layers of connective tissue. Name the process detected in myocardium. Okay. D. Nothing is difficult with this case. I guess you understand this pretty well. There are few keywords over here. First, atherosclerosis, atherosclerotic plaques. That's why it's not likely to be the myocarditis. We just can, you see, completely reject this distractor. But all others, like tiger heart, post-infarction cardiosclerosis, or myocardial infarction, or diffuse cardiosclerosis, what you have chosen as the correct answer, they could be present in this condition. But we have to exclude them. First of all, numerous whitish layers of connective tissue. Momentarily, at the moment, exclude the tiger heart. And for sure, the myocardial infarction, because that's not about the necrotic area. What about the other types of cardiosclerosis? We have dealt with the cardiosclerosis for sure, because there is the connective tissue development. But this cardiosclerosis is explained as the numerous whitish areas, but not like one focus of the connective tissue development. So that's not post-infarction cardiosclerosis, that's diffuse cardiosclerosis, and this is the logic of this MCQ. As the confirmation of that, we have dealt with the atherosclerosis, obstruction of the coronary arteries, no more than 1/3 of the lumen, arterial lumen, or arterial opening, how it appears here. So that's why there is no chance for development of the myocardial infarction over here. Only continuous chronic process which is associated with the development of the diffuse cardiosclerosis. Next question. Microscopy of the myocardium of a girl who died on diphtheria due to heart failure shows fatty degeneration, multiple foci of cardiomyocytes necrosis, and small foci of cellular infiltrates in the interstitium. What type of myocarditis is it? You have started answer, and you consider that as B. What I should say here, this is exactly the case when you just have to memorize this terminology, because there is a problem with terminology over here. You should understand that. Alterative myocarditis, that's the misnomer. That's the complete misnomer. You can make a search on a Google. You can make search on PubMed or some other reliable sources about the medicine, and you won't find this type of terminology in the Western medical terminology. So ulcerative inflammation, ulcerative myocarditis, that's the term that appeared in the Soviet school of pathology, because it was the conception that there are 3 stages of the inflammation, like alteration, exudation, and proliferation, and according that we can conclude 3 types of inflammatory process with the pronounced stage, like alteration, with pronouncing of alteration in the inflammatory process lead to the appearance of the term ulcerative inflammation, exudation, correspondingly exudative inflammation, and proliferation, proliferative inflammation. And at some point that's true, but in fact alterative inflammation, alteration by itself is something which is preceding inflammatory process. That's the necrosis, that's the cell injury. And you remember we discussed about cell injury before inflammation topic. That's why alterative inflammation you will never find in the Robbins, for example, and you will never meet this term in your real life. That's why in this case you just have to remember this terminology. Alterative inflammation is associated with diphtheric injury of the cardiomyocytes, and this is the Ukrainian reality over here. That's why correct answer is B. Yes, that's B, alterative. So what you should see here, you should see the keywords like multiple foci of cardiomyocytes necrosis. And the logic of this type of inflammation, if it would be existed, that in this case we see the prevalence predominant pattern as the necrotic changes in the cardiomyocytes. So you see the multiple foci and small foci of cellular infiltrates in the interstitium. So if you have the temptation to choose something like interstitial inflammation over here, you should decline that, because you see in this case we have the prevalence of necrosis over the cellular infiltrates in the interstitium. So that's why the logic of this, you have to choose alterative inflammation. Okay, the next question. 40-year-old man developed skin redness and swelling in the neck area, where eventually a small abscess appeared. On section, the focus is dense and yellow-green colored. In the purulent masses, there are white granules. Histologically, there are fungal druses, plasma and xanthoma cells, and macrophages detected. Specify the most correct etiological name of this pathological process, please. D. You have chosen actinomycosis. What is the logic over here? Of which keywords you have to choose? So first of all, look at the most important keyword. That's the presence of the fungal druses. Fungal means fungi origin, fungal origin for sure, like molds or something, and druses, that's the conglomerates, the clusters of the fungal glyphs, which are arranged in the like foci, rounded foci with this star-like appearance. I didn't prepare the image for you just to remind you, but doesn't matter. Fungal druses helps you a lot over here. However, actinomycosis, that's not the fungal infection. Again, that's the misnomer. Anyway, this etiological factor is behaving as the fungus, is like building the colonies like the fungi infection. So that's why you have to choose the actinomycosis over here. That's the correct answer. For sure, in case of the furuncle or carbuncle, we will rather have the presence of suppurative inflammation and widespread neutrophil infiltrate, polymorphonuclear infiltrate. So in this case, there are purulent masses, but the presence of fungal druses. In case of syphilis and leprosy, we don't have any presence of purulent masses. Rather, we see the granuloma formation, or in case of the syphilis, we have deal with the endovasculitis. Over here, nothing like this appeared in the question. That's why actinomycosis is the correct answer only. Okay, next question. Kidney to be swollen and plethoric with easily removable capsule. Okay, Rabah Buraya, you wrote about the present in the neck with yellow-green liquid. Okay, just returning to previous. Yellow-green liquid that just passed. That's suppuration, and it could be present at furuncle also or carbuncle. That doesn't specify that this is exactly actinomycosis. Xanthoma cell, Ravi Ranjan wrote about xanthoma cell. Okay, xanthoma cell, again, this non-specific appearance of the transformation of macrophages in the presence of any foreign material engulfment. After the digestion of foreign material that contains some fat, some lipids, we may see the appearance of transformation of macrophages into xanthoma cells. That's macrophages filled with the small foamy vacuoles that consist lipids. That's why in this case, fungal druses, that's only keyword that will help you. Specific in the neck. Okay, in the neck there are a lot of things. Okay, yes, actinomycosis could be present in the neck. Actinomycosis could be present in the facial or orofacial area, but in the neck we can expect syphilis, we can expect tuberculosis, we can expect other purulent inflammatory disorders, not exactly connected with actinomycosis. So don't connect actinomycosis strictly with the neck. Okay, it's like the additional, we can consider like additional attribute to that, but the most important thing in this case, there's the fungal druses. If otherwise, no other mycotic infection over here. Okay, let's turn to the next question. A renal examination shows the kidney to be swollen and plethoric with easily removable capsule. Renal pelvis and calyces are dilated and filled with turbid urine, opaque urine. The mucosa is dull and has hemorrhagic foci. On section, the renal tissue is variegated or motley. That's a very cool word, variegated. The synonym of that is motley. There are yellow-gray areas surrounded with plethoric and hemorrhagic zone. Which disease can be characterized by such result of microscopic gross examination? Acute pyelonephritis, you think? C. And that's right. So everything which is indicated in bold font just suggests you that this is exactly the acute condition, because we have deal with the swelling, plethora, we have deal with the motley pattern of the cross section of the kidney, and what suggests us that this is the pyelonephritis, not glomerulonephritis, that we see the involvement of pelvis and calyces. So this is the key words that and connections that will help you to finally conclude this answer as the only correct. Because in case of polycystic kidney, we will see the multiple cysts. In case of nephrolithiasis, we have to expect rather presence of the stones, kidney stones, and we have to expect the development of hydronephrosis. Renal amyloidosis will appear as you remember, a large Lardesius kidney. It will be brittle, it will be dense, very dense, not swollen or plethoric, and it will be pale. In case of the glomerulonephritis, we will rather see the multiple hemorrhages, small hemorrhages all over the parenchyma, and no involvement of the pelvis and calyces in that case. So the acute pyelonephritis, according to this logic, is the only correct answer. Next question. That's quite difficult question, but you should remember something about that, I guess. Autopsy of the body of a 50-year-old man who had been suffering from tuberculosis and died of cardiopulmonary decompensation shows lobar affection of the lungs. The upper lobe of the right lung is enlarged, dense yellow on section, crumbling with pleural fibrin deposition. What type of secondary tuberculosis can be characterized? Okay, you proposed D and A. Great. Ravi, you proposed A. Quite interesting. Look, first of all, what we have here, we see there, what is the level of the pulmonary involvement in this case? So look, we got the infiltrative tuberculosis, we got the tuberculoma, we got the fibrous focal tuberculosis, so we have the acute focal tuberculosis. So in case of infiltrative tuberculosis, we can see the involvement of pulmonary tissue, on widespread involvement of pulmonary tissue, but in that case we don't have any involvement of the pleural, pleurisy. In case of fibrous focal tuberculosis, we have deal with the focal area with the distinct dense fibrous capsule around that. So that's not like here, not the injury, not the affection of the entire lobe in the lung. Tuberculoma, again, looks like a tumor, has the rounded structure filled with caseous masses, and again, there is no involvement of lobe, entire lobe, neither involvement of the pleurisy. Acute focal tuberculosis, again, is associated with the focal injury. In our case, we have deal with the lobar affection, and upper lobe is involved. We see the presence of pleural effusion, the fibrin deposits, the reaction of the pleurisy. So all of these keywords suggest us that caseous pneumonia, that's the only correct answer. So just to remind you the different types of the tuberculosis and different the evolution of tuberculosis. You should remember the primary complex, progressive primary tuberculosis, miliary tuberculosis, and secondary tuberculosis. In our case, we have deal with the progressive type of secondary tuberculosis with the involvement of entire organ. That's not the localized form. So the correct answer is D. Next question is quite confusing. Again, it's just the questions. Sometimes the questions are going out of logic. We just have to memorize things. And that's the same case. Autopsy of the body of a man who for a long time had been working at the factory with high content of silicon dioxide in the air revealed and revealed enlarged dense lungs with numerous round and oval sclerotic foci. The foci were miliary and larger in size and colored gray or gray-black. What is the most likely diagnosis? Okay, you have chosen A. You already remember this. So in this case, exactly silicon dioxide. That's the silicosis for sure. So we just can exclude at first the asbestosis. Then we have deal with the presence of numerous rounded oval sclerotic foci. So foci, focal appearance, not diffuse, not regular presence of the sclerotic tissue. No, this is the nodal appearance, the focal appearance. This focal appearance have to conclude, lead to the conclusion that this is the nodular silicosis, but there is something that distract us from that. You see, the presence of gray and gray-black coloration of this foci. And at such point, we may conclude that this also the anthracosilicosis or silicoanthracosis. So don't be deceived by that. Don't be deceived. We have two major forms of silicosis. That's nodular and diffuse sclerotic silicosis. That's Ukrainian school, Ukrainian classification. Just remember that. In case of anthracosis, we have deal with the prevalence of the coal particle accumulation. But in this case, there is no prevalence of coal particle accumulation. That's just fates of this white foci, fates in gray or gray-black. So just don't pay attention on that. Pay attention on silicon dioxide as the primary cause of this pneumoconiosis. That's why that's silicosis, and that's why that's nodular silicosis. Next question. Acute renal impairment caused death of a patient with hemorrhage. Autopsy revealed enlarged kidneys with broad pale pink cortical layer, expressively demarcated from dark red renal pyramids. Macroscopic examination revealed lack of epithelial nuclei of the convoluted tubulis, tubulorexis, phlebistasis. The cell nuclei of the choroid, glomus, and straight tubulus were present. What pathology is it? What is the pathology here? Look here. That's exactly what I explained here. That's the pale cortex, dusky red medulla. On the left, there's the grossing. And on the right, you see the microscopy of this case. Again, the necrosis of the convoluted tubuli. You see the absence of the nuclei. You see the tubulorexis. That means that detached, desquamated, necrotized epithelial cells completely filled the lumens of the convoluted tubuli. However, you see the glomeruli, and you see the straight tubuli, collective tubuli, which are not involved into this process. And the only conclusion here, there's the acute tubular necrosis, which is associated with the hemorrhage, severe hemorrhage, which led to the hypovolemic hemorrhagic shock. And the acute tubular necrosis or necronephrosis, that's exactly the morphological changes, morphological diagnosis of the kidneys involved into the shock process. Next question. Autopsy of the body revealed waxy degeneration of the rectus abdominis muscles. First keyword. In the terminal segment of the small intestine, there are ulcers 3 to 5 centimeters in diameter. The ulcer walls are covered in a crumbling grayish-white substance. The ulcer edges are markedly raised above the mucosa. Vidal test is positive. Make the diagnosis. So Vidal test, it's the key word that suggests us that this is the infectious process. The presence of the ulcers in the terminal segment of small intestine, so the ileum, right, in the ileum, again suggests us to the one certain type of infection here. There's a typhoid fever, right? And the vaccine degeneration or Zenker necrosis, that's exactly the characteristic type of necrosis in the muscles, which is connected, associated with the intoxication, with the release of the potent endotoxin of the causative agent of typhoid fever, which is Salmonella typhi, as you remember. Typhoid fever is the correct answer, right? Let's go further. 30-year-old man has undergone surgical removal of a thyroid tumor. Histologically, the tumor is made up of papillary structures varying in size that emerge from the inner surface of dilated cystic follicles and are covered with atypical epithelium. What is the most likely diagnosis? Okay, C, papillary structure, papilloma, perfect. Aburaya Rabah, thank you. You found the connection. That's obvious connection. Yes, sure. Papillary structure equals papilloma. But in our case, we have no papilloma, right? Can you please tell me main keywords for the pyelonephritis and glomerulonephritis? We will turn back to that later. Okay, for pyelonephritis, pyelos means the pelvis of the kidney. For pyelonephritis, the involvement of the, let's turn back to that. Oh, okay. Missed that. Okay, over here, see the pelvis and calyces, they are involved. See? Pelvis and calyces. In case of the glomerulonephritis, we will rather see, first of all, we won't see the involvement of pelvis. And in case of the acute glomerulonephritis, we also will see the motley appearance of the renal tissue. But in that case, we will see the small hemorrhagic zones, like the diapedesis, small diapedesis all around the parenchyma, without any involvement of the pelvis. So that's why here the connection, that's the pelvis and calyces. Pelvis and calyces, connection to the pyelonephritis, not glomerulonephritis. Remember that. So let's turn back to the papillary structures. Okay, here, what is important for us? Papillary structures, sure, that's something that suggests us the correct diagnosis. But what else? Other keyword. That's the atypical epithelium. Atypical epithelium and papillary structures. From this point, we can exclude something which is not malignant, because atypical epithelium, that's the attribute to the malignancy, to the malignant tumor. In our case, colloid nodular goiter must be included at first. Second, macrofollicular adenoma must be excluded at second. So then, as the rest, we have the carcinomas, 3 carcinomas. And from this point, papillary, that's another keyword that will help us to conclude that this is exactly papillary carcinoma. This is what you must know about this case. And this is the logic of this case, papillary carcinoma. Okay, next question. Histological analysis of a removed skin tumor shows clusters and bands composed of atypical stratified squamous epithelium cells that penetrate into the underlying tissue. What preliminary diagnosis can be made? Okay, your variants: C, 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 what else? C. Well, keywords, that's the tumor. Great. So all of these options, all these structures, they're about the tumor. That's good. Anyway, we have deal with atypical stratified cells. That's why that should be considered as the cancer, but not the benign tumor. Atypical cells, that's the attribute to the cancer. So we just can exclude adenoma and papilloma. And yes, Rabaru Aburaya, thank you. That's cause. We have deal with penetrating into underlying tissue, into the dermis. So in such a way, we may exclude carcinoma in situ, but still we have deal with the solid cancer and non-keratinizing squamous cell carcinoma. As about the solid cancer, we should have some kind of the solid mass. But in this case, we just have the infiltrative tumor, which is exactly consists of squamous epithelium. You see, in solid cancer, there is no specific terms associated with the type of the tissue. In this case, in case of non-keratinizing squamous cell carcinoma, everything is matching each other. That's exactly carcinoma. That's exactly carcinoma associated with the squamous epithelium, and there is no mentioning of the so-called pearls, cancer pearls, as you remember, which means the formation of the keratinizing areas in this cancer. So that's why that's the non-keratinizing squamous cell carcinoma. That's the logic of this MCQ. Great. Next question. Autopsy of a patient who died of bilateral bronchopneumonia shows in the left lung lower lobe a cavity 5 cm in diameter, filled with yellowish white liquid. Which complication of the patient's pneumonia had developed? Easy, easy, very easy. Bronchopneumonia or focal pneumonia, right? Basically associated with, that's acute type of pneumonia, which is associated with the purulent inflammation, first of all. So as the logical and most common complication of that, that's the formation of the purulent localized inflammation that we call abscess. And exactly everything is matching here. That's the cavity, 5 cm in diameter, filled with yellowish white liquid. That's the pus, and that's the abscess. How to exclude other options? That's quite easy again. You see the gangrene. Mostly we must see some black changes in the tissue, black coloration of the tissue with the bad smells. Then the granuloma formation, again, that's the focus of white color, and basically is associated with the tuberculosis in such a way, the caseous masses. The sequestrum, that's the restricted area of the necrotized tissue, but not the presence of yellowish white liquid for sure. And again, tuberculoma is basically associated with the caseous necrosis. Next question. Patient presents with enlarged cervical lymph nodes. Other lymph nodes and internal organs are without changes. Peripheral blood test results are normal. Histological examination of biopsy material taken from the cervical lymph node shows smoothed out pattern, absent follicles, homogeneous cell composition represented by lymphoblasts. These cells penetrate into the lymph node capsule, where diagnosis can be made. C, Mohammed Ibrahim, CC, okay? What else? Good. over here, we have deal with the lymphoproliferative disease. And all of the options are somehow associated with that. But you have some suggestions which will help you to solve this MCQ. First of all, what we see the involvement of the lymph nodes. Lymph node involvements, and you see the other internal organs are without changes. We also see the involvement of the cervical lymph nodes, so that's several lymph nodes which are involved to the process. That's not the single lymph node, right? So the next point, the cells which are present on the biopsy material from the lymph node. You see that this is mostly the lymphoblasts, and we see that we have the homogeneous composition of the histological image over there, which suggests us that this is some lymphatic lesion, lymphatic tumor from the lymphocytes. In such a way, we can exclude myeloblastic leukemia and erythroblastic leukemia, because A, B, and C options, they are associated with lymphomas. But Sézary disease is basically associated with the skin lesions, skin lymphoma. There is no involvement of skin here, right? Then, lymphoblastic leukemia and Burkitt lymphoma. As you remember, Burkitt lymphoma mostly involved the cervical lymph nodes too. But in that case, we have the isolated injury of single lymph node. Moreover, in that case, we will see the very specific histological pattern. Remember, Burkitt lymphoma is associated with the starry sky appearance. We also will see the homogeneous composition by tumor lymphocytes with the scattered presence of apoptotic bodies scavenged by macrophages. And these macrophages with apoptotic bodies looks like the stars on the dark sky. This dark background is composed by tumor lymphocytes. In our case here, we don't see any star-like starry sky appearance. We just have homogeneous cell composition. Moreover, there is the strict suggestion, strict tip for you, direct tip, that's the lymphoblasts. So without any doubts, choose lymphoblastic leukemia. That's the correct answer. Next. A young woman presents with a tumor along the auditory nerve. The tumor is node-shaped, 3 cm in diameter, soft and elastic, pink-white colored, and has homogeneous structure. Morphologically, the tumor contains bundles of cells with oval nuclei. These cellular fibrous bundles form regular structures made up of parallel rows of regularly oriented cells arranged in the form of a palisade with acellular homogeneous area in between. That's the Verrucai bodies. Name the time of this type of tumor, please. What are your suggestions? D. Okay, I just wanted to show you something just to make this knowledge stronger, much stronger than you have, just to associate this question with the direct histological images. And I wanted to find something like the Verrucai bodies on the yeah, just a moment. I want to share with you another page. Well. Yeah, that's here. So Look, this is exactly what we have deal with. That's the verrucai bodies. You see the nuclei of the cells arranged in the palisading structure. It's like the palisades. You see around the house, like for example, palisades with carrot or potato, whatever, and you see some spaces between them. So altogether, these palisades with these gaps between them create the term that we call verrucai bodies. And this is exactly the Schwann cells which are growing in the tumor that we call, we call it schwannoma. But you see the alternative name, the synonym of schwannoma is the, just a moment, yeah, that's the neurinoma. So in our case, D called schwannoma that affect the peripheral nerve. Yeah, that's neurinoma. That's the synonym of schwannoma. From this point, we can exclude ganglioneuroma. We can exclude, just a moment, we can exclude neuroblastoma, ganglioneuroblastoma, because they are definitely don't contain this kind of pattern, like verrucai bodies and palisade structures. Malignant neurinoma, however, also may contain some kind of the verrucai bodies, some amount of them, some amount of palisade structures. However, in that case, we won't see some kind of regular orientation of cells. Moreover, we will see the atypism of the cells, because that's the malignant neurinoma. You see here, there is no mentioning about the atypical cells, right? About the atypism of the cells, about the invasion of this tumor. You see, there's the node-shaped, 3 centimeter in diameter, soft and elastic. You see, there is no presence of invasion. There is no presence of malignancy over here. That's why we must conclude that here only correct answer as the neurinoma. Next question. When examining a biopsy material obtained from the thyroid gland, the pathologist discovered lymphocyte infiltration of the thyroid tissues and destruction of the, we can call it as neurilymoma. Yes, Pradeep, sure, neurilymoma, neurinoma, schwannoma. Okay, schwannoma is the most common term. If you want to impress somebody, you can call it neurilymoma. In such a way, you just demonstrate that you know the origin of this tumor. That's neurolymphocytes. You know the alternative name of that. Okay. When examining biopsy material obtained from the thyroid gland, the pathologist discovered lymphocyte infiltration of the thyroid tissues and the destruction of the parenchymal elements. Diffuse lymphocyte infiltration with lymphoid follicles was detected in the stroma. What is the most likely diagnosis? Please, your variants, people? Ah, sorry. I don't see. I don't show. Yeah, sorry. I want to stop my screen. I want to stop my screen and want to be focused on the presentation. Okay, do you see that now? Hello, people? Now it's good? Okay, D, yes, perfect. D, Hashimoto thyroiditis. And yes, sure, you see the lymphocyte infiltration in the thyroid tissues. If you see the infiltration by lymphocytes, we can conclude some kind of thyroiditis. About the thyroiditis, we have only one option here. Moreover, if even we will have some other options with the thyroiditis or inflammation, the presence of lymphoid follicles over here is suggesting us that this is exactly the Hashimoto's thyroiditis, because Hashimoto thyroiditis is associated with the formation of the lymphoid tissue directly in the thyroid gland. So, also known as chronic lymphocytic thyroiditis, yes, for sure. Yeah, and thyroid gland is gradually destroyed. Perfect. Yeah, we see the destruction of the parenchymal elements because sure, that's the autoimmune injury of the thyroid cells. Yes, thank you for your help. Autopsy of the body of an elderly man revealed yellow spots and sticks in the aortic intima and white yellow protruding plaques in the area of aortic bifurcation. Microscopy with hematoxylin and eosin staining shows round cavities in the thickened aorta intima. The cavities color orange, then stained with Sudan 3 and are surrounded with overgrown connective tissue. What process developed in the aortic intima? Ayush Gayal. B. Who else? Pradeep. B. Ravi. B. Okay. So look what we see here. We have deal with the yellow spots and streaks in the aortic intima. White yellow protruding plaques in the area of aortic bifurcation. So most likely that's the atherosclerosis, right? The only thing that we have to conclude here, with which metabolic disorder atherosclerotic is associated. Is it associated with the hyalinosis? No. Systemic? No. Amyloidosis? Not likely. Not at all. Neutral fat? No. That's only associated with the cholesterol metabolism and for sure with its ethers. So that's why B, that's the only correct answer. You see, we are on the merging between biochemistry and pathomorphology here. So anyway, as you know that this is the atherosclerosis and you know something about biochemistry of that and pathophysiology of that, so it would be very good for you. Autopsy of 50-year-old woman who has been suffering from systemic connective tissue disease reveals small dense kidneys with lumpy surface. See, before that we have dealt with the enlarged kidneys. Here we see the small dense kidneys with lumpy surface. Microscopy of the renal glomeruli detects the foci of fibrinoid necrosis. Fibrinoid necrosis. Small kidneys means it was the chronic process that led to the atrophy and sclerosis of the kidney. Then fibrinoid necrosis, you know that mostly fibrinoid necrosis is associated with the autoimmune diseases, right? Hyaline thrombi, again, autoimmune changes. Hematoxylin bodies, again, this associated with certain type of the autoimmune disorders, and so-called wire loop thickening, which is strictly associated with the systemic lupus erythematosus. Sorry, I spoiled this question because I turned right to the right answer. Yeah, sure, that's systemic lupus erythematosus. What is suggestion to you about that? Wire loop thickening, first of all. That's the glomerulus involvement into this process, glomerular apparatus involvement with the injury of the basement membrane, with the characteristic wire loop thickening. Presence of hematoxylin bodies, that's very characteristic for the systemic lupus erythematosus. All other attributes, that's the attributes which could be associated with other autoimmune disorders too, but altogether make our conclusion more clear. So people, I guess that's pretty clear in this case that systemic lupus erythematosus is the correct answer. Next question. Histological investigation of the uterine scrape of the 45-year-old woman with disturbed ovarian menstrual cycle revealed increased number of endometrial glands, some of which are serrated, while others are dilated and cyst-like. Make the diagnosis. So while you're thinking about that, I just want to find the appropriate image of that just to make your connections much stronger. Okay, endometrial hyperplasia histology. Let's check it. Just a moment. I want to open this image. Yeah, that's it. Let me share that with you. Again, let me know if this web page will be visible for you. Just a moment. That's the bookmark. Yeah. What about now? Do you see that? That's the endometrium biopsy. And you see exactly what they explain, the cystic changes in some glands and serratic appearance of others, like here. So still, we have deal with the non-atypical endometrium. The cells, the stromal components, the epithelial component, they are pretty good. They look normal. They like normal endometrium. However, the architecture, the ratio between stromal and epithelial components, a little bit changed. And in this case, we have deal for sure not with the malignancy. That's not the malignancy at all. So I just switching back to the presentation. Do you see the presentation now? Everything is okay? People, your feedback? Where are you? Everything is okay? Do you see the question? Yeah, perfect. So look here. If we're talking about the disorder of the benign character, for sure that's not the adenocarcinoma. We're just excluding the adenocarcinoma at first. Then we have deal with the several types of benign lesions of endometrium, like placental polyp. In case of placental polyp, we should see the remnants of the decidual layer, and we should see some villi of the chorionic villi. In this case, we have deal only with the glands of endometrium. Glandular endometrial polyp. In case of polyp, we should see the polyp. See the lesion which is surrounded by the some covering epithelium, and which is looking like the mass protruded into the lumen of the uterus. In this case, we just see the normal endometrium, almost normal endometrium with some cystic lesion. And in this case, for sure, there is no atypical changes. That's the normal endometrium, as I told you, normal endometrial cells. So that's the endometrial cystic glandular hyperplasia. That's the correct answer. Next question. 45-year-old man diagnosed with hepatic cirrhosis and ascites underwent drainage of 5 liters of fluid from his abnormal abdominal cavity, which resulted in development of syncopal state due to insufficient blood supply to the brain. What kind of circulatory disorder occurred in the abdominal cavity in this case? Please. Arterial hyperemia, BBB. Okay, great. That's so-called post-anemic hyperemia. So in fact, in theory, we have deal with the ascites and ascitic fluid, which compressed microcirculatory bed in the peritoneum. After the release of the ascitic fluid from the abdominal cavity, what is important here, the fast release. See the fast drainage. The blood from other compartments of our body filled previously collapsed capillaries with blood, and in such a way we have deal with some kind of deficiency, like rapid deficiency of blood in other compartments of our body, like in the brain. So that led to the collapse, and it led to the loss of the conscious. For sure, that's temporary. That's so-called type of the collapse, type of the unconsciousness, but that's very, very temporary. And for sure, that's associated with the arterial hyperemia, exactly in the abdominal cavity. So that's not the venous hyperemia, that's not the ischemia. Ischemia happened before, and now there is some kind of ischemic changes, ischemic condition in the brain, temporary for sure, but not in the abdominal cavity. And for sure, that's not associated with the thrombosis or embolism. So arterial hyperemia is correct answer. So people, that's almost all. I just want to tell you that some questions like this, this, and this, we discussed, and this question too, we discussed before, we discussed on Tuesday, and you can find all answers, all the solutions of these questions from 2018 in 2019 questions. What I repeat, would like to repeat again, we discussed profoundly on Tuesday. So please find the YouTube video and rewatch it, rewatch our analysis of those questions. Again, with connections, with keywords, everything what you need to obtain the logic of these MCQs and to memorize them better. But that's not all, people. Please, first of all, I wanted to, you know what I wanted to do? It's something like a ritual. Yeah, I wanted to wish you good luck on the Krok 1 exam, please. And also, directly now in the chat, I want to send you the link to an MCQ trainer. However, this link I will put in our Facebook page. Do you remember our DMA pathology department? So please don't forget to join it if you didn't, because all information about the links, about the videos for Krok 1 preparation, you may find over there. But also the moment, that's the Facebook. You will find the link on the Facebook. I just wanted to go there, but somehow. Yeah, just give me a few seconds. I will send you the link, and in such a way I can release you. No, I can't. Okay, don't worry, people. I want to open my something different. My disk. That's here. Just a moment. Yeah, Krok training 2018. So on this trainer, you will see 26 questions. As soon as you will answer them, you will respond on this form, you will receive the feedback, you will receive your result immediately. You shouldn't wait. Moreover, you can repeat this trainer, you can repeat these questions again and again until you will obtain the appropriate result. Appropriate result, I mean 26 from 26, 100%. That's why, please don't hesitate and repeat it several times until you will be perfect on this trainer. So you see now the link. Please follow this. And on the Facebook and our DMA pathology department page, on our page, you will find the link from previous trainer for 2019 questions. There are 22 questions associated to, connected to pathomorphology. Please do them too, together with that. And tomorrow I will perform another Google Meet, and I will prepare another trainer for 2017 Krok 1 exam and the pathomorphological question from there. So don't miss it too. So watch the videos, subscribe on our YouTube channel, like our videos too, and please train as much as possible, as more as possible, as better as possible. Okay, I believe in you, so please pass Krok 1 very good, pass Krok 1 at all, and good luck. Have a nice day. Thank you for watching.